Hello, everybody. We got the go ahead and get going. So we will. Welcome to the 17th annual Pomerantz Visiting Lectureship. This year, we're very delighted to have Mac DeCamp from Wisconsin here. And I'll introduce him in a second. But first, I want to say a few things about Marv Pomerantz. You know, we're 17 years since he retired. Not many of you have probably met Marv, but it's your loss because he was a real force. Marv was born just outside of New York City. He went undergrad at Colgate. He went to the University of Rochester Medical School. And then he went down to Duke, where he spent a decade down there with Dr. Sabiston, being trained in general and cardiothoracic surgery. During that time, he also spent 2 years at the National Cancer Institute. In 1967, Marv was recruited to Denver to start a cardiac surgery program at Denver General Hospital. And he was recruited by Ben Eisman. He stayed at that and actually developed a very successful program, but then left in the 1970s to start a private practice here in Denver, which he did for a couple of decades. And he was also very successful at that. In the early 1990s, Dr. Grover recruited Marv back to the faculty here at the university, where he headed the general thoracic effort until his retirement in 2004. Now, Marv was an outstanding clinical surgeon. He was my partner when I first got here. He's just a terrific surgeon. One of the things he's known for the most is really starting and continuing the mycobacterial program, the surgery for mycobacterial disease. And he was recognized as a world expert in operating on patients with tuberculosis. He was active in a lot of societies. He was the president of the Western Thoracic. Marv in the 1990s was on the American Board of Thoracic Surgery, and in the late 90s served at the chair and actually signed my certificate. He was also an avid tennis player, as a state tennis champ, avid golfer. You could ask Dr. Cleveland for details, but really a terrific athlete. In 2004, he and Peggy moved to Tucson, where he retired. I spoke with Marv yesterday. He's doing well. He regrets not being able to be here, but travel now for him is a little difficult. So cheers to Dr. Pomerantz. Now, to our visiting professor, Mac DeCamp was born in Louisville, Kentucky. He went undergrad at Harvard, where he played football, and I dare say played at a higher level than we've been used to recently around here. He then went to medical school at the University of Louisville, and then spent 10 years at Brigham and Women's Hospital in Boston, where he went through residencies in general surgery and cardiothoracic surgery. Over his career, he's held faculty appointments at a number of prestigious institutions. He joined the faculty at the Brigham and then went to Cleveland Clinic, and then came back to Boston at Beth Israel, where he ran the cardiothoracic program. He then went to Northwestern and now is the chair of cardiothoracic surgery at the University of Wisconsin. Mac's extremely well known, not only nationally, but internationally. He's a very productive academic career. He's won numerous awards. He has over 150 publications, extremely well funded, and has served in a variety of levels and organizations and societies, both nationally and internationally. So there's two things I want to highlight about Mac's career. The first is, while he was at Beth Israel, he formed the first combined cardiothoracic and interventional pulmonary service or group unit in the country. And this led to Beth Israel being recognized as a national referral center for various thoracic diseases, particularly of the airway. Second, Mac was a driving force in the planning, the execution, and the analysis of the National Emphysema Treatment Trial, which was really a landmark randomized trial in thoracic surgery regarding the treatment of emphysema. And I think he's going to touch a little bit on that in his talk. The title of his talk is "Do Randomized Controlled Trials Really Change Practice? A Cautionary Tale." Dr. DeCamp.
Thank you, John. Let's see if yeah. Okay, is this working? Awesome, thank you. Well, I want to thank Dr. Mitchell and all friends and colleagues here at the University of Colorado for this kind invitation. I had the pleasure to get to know Dr. Pomerantz mostly through the General Thoracic Surgery Club, and I enjoyed hearing some of the golf tales with Dr. Cleveland last night. In thinking about what to talk about, I thought I would touch on the emphasis on evidence-based medicine that we all strive to, perfect and deliver to our patients, but also a little bit of a few words of caution about what's held to be the gold standard of evidence-based medicine, which is the randomized controlled trial. So I'm going to use a couple of thoracic specific examples that John mentioned, the NET trial and also the National Lung Screening Trial. I don't have any relevant financial disclosures other than I get to work with Dr. Mitchell and Dr. Fullerton on the American Board of Thoracic Surgery, which has been really a very enjoyable aspect of my career. So what do you need to do a randomized trial? You have to have a new or an innovative device or procedure or treatment that you want to propose and compare to the standard of care. And then there's generally disagreement in the medical community about whether that should supplant the standard of care, whether it's equivalent to or superior to. And that's the term equipoise. And I didn't really know what equipoise meant until I was involved in sort of the whole lead up to the National Emphysema Treatment Trial, where it was quite clear that there was not consensus in the medical community around the utility of this new operation. So I did what you're supposed to do before a fancy talk like this. I went to Google and Googled equipoise and tried to figure out what it was and who has it. And so if you Google equipoise, this is the first thing that pops up, which turns out to be an equine, anabolic steroid that you can purchase right off the web. That's Dr. Mitchell right after his workout, getting off his Peloton. But that's not the equipoise we're here to talk about today. If you look back in the literature, Benjamin Friedman wrote this nice essay in the New England Journal in the late 80s about the ethics of clinical trials, or ethics of randomized trials in clinical research. And he has a few principles that I think are good for us to remember. One, there has to be an honest professional disagreement about what we're proposing. And that equipoise really exists within the medical community, not necessarily within the individual, especially since the room's full of surgeons. Usually we don't have equipoise. We're right or wrong, but never in doubt. And so a randomized trial is one way to try to solve that lack of consensus, if you will, and resolve the dispute. So, in the very simplest form, equipoise should be completely balanced. That's not how the world works. More the bottom right, you might have like all of our medical colleagues as this giant boulder on the right and a few outspoken surgeons as the three little rocks on the left. And that's what I'm going to use as the sort of basis for what we want to talk about today. And I want to pick some big problems. So whenever I have a chance to talk about lung disease, I grew up in Kentucky. The number one legal cash crop in Kentucky was tobacco. Colorado's figured out how to make the other number one cash crop financially lucrative. But let's talk about tobacco-related illnesses and I'm going to focus both on COPD or emphysema, and then towards the end more on lung cancer. But they're responsible for close to 500,000 deaths in the United States alone each year. And so, as a public health service, anything we could do about tobacco control would have a great impact on the mortality and morbidity of our country. So let's talk first about COPD. It's the number 4 leading cause of death in the world right now. It's responsible for about 3 million people dying every year. We'll get to lung cancer a little bit later. And you recognize this as emphysema. It's the destruction of the gas exchange units in the lung. They're sort of blown apart, and you lose that surface area for gas transfer, and the lungs get bigger and bigger and bigger, and then they don't fit in the chest anymore. So I think these nice air dried pictures, I've shown this to a few patients to try to explain, what the whole process is about. It's a big problem clinically in our country. About 2 million patients have COPD. As we know, COPD is a spectrum of chronic bronchitis to emphysema. Emphysema is the anatomically destroyed lung. It's not going to get better. The chronic bronchitis is what we modulate with all the therapies for COPD, other than what we're going to talk about here. It's responsible for a lot of healthcare expenditure. 500,000 people visit their doctors for this. Frequent admissions to the hospital for, quote, COPD exacerbations. It's the 4th leading cause of death in our country and around the world. And it's responsible for somewhere between $1 and $5 billion of healthcare expenditure each year. So it's a big problem. Prior to the NET trial, which we'll talk about, there's really been one intervention that has been shown to enhance survival in COPD, and that's supplemental oxygen. You could make an argument for some of the vaccinations that we have embedded in primary care for flu and community-acquired pneumonia. But there's 2 studies that were both published within a month of each other, one at the very end of 1980, one at the very beginning of 1981, both done in the United Kingdom, showing that patients that have documented desaturation do better if they wear oxygen at night. That's the MRC study that was published in Lancet in January of 1981. And if nocturnal oxygen is better, so 24-hour oxygen ought to be even better than that. And this is the NOT trial, hence where NET maybe came from. But this is the nocturnal oxygen treatment trial that was published in the Annals of Internal Medicine in December of 1980, showing a statistically significant survival advantage for patients who had known desaturation who wore supplemental oxygen. The only thing that's been shown to enhance survival in COPD in certainly our professional lifetime. So that is a bit of the background for what's happened. Everything else that's happened in COPD has been this inhaler or that inhaler that gives you a 2, 3, 4, 5% improvement in, pick the endpoint, FEV1 or whatever it might be. Some of these things that are statistically significant, but of questionable clinical relevance for like 30 years. Otto Brannigan was a thoracic surgeon in Maryland in the 50s and 60s who began to explore trying to better understand the physiology of why people with bad emphysema are so dyspneic. And he postulated that, and I like this analogy, he's taking a 6 or 7 liter organ and stuffing it in an inelastic, inflexible 5 liter container. And if you notice the normal lung, the small airways depicted here depend on these parenchymal tethers to keep them open during the respiratory cycle so they don't close. And in COPD, as the lung gets bigger and bigger and bigger, these parenchymal tethers are no longer under tension, and the small airways close and leave trapped gas in the chest, and the patient becomes progressively more hyperinflated. And it's that hyperinflation that seems to drive that sensation of dyspnea. So when I see patients with COPD in my clinic, usually with their family, I say, all right, take the biggest breath you can and hold it, and now take another breath. And they try to explain that physiology to the family. I said, this is where your loved one lives all the time. They get a little excited, they breathe a little fast, they get more hyperinflated, and they're incredibly uncomfortable. So Brannigan at least published about this in the late 50s. And he's like the grandfather of lung volume reduction surgery. In this same era, he devised an operation with staged bilateral thoracotomies with a cut and sew approach to doing volume reduction surgery in an effort to treat this hyperinflation. And that's one of the things that precipitated NET. And if you look back, like this experience of 29 patients was published in 1959, but it had an excessive mortality, 30% mortality. So not ready for prime time. You got to remember in 1959, there were no ICUs. The double lumen endotracheal tube was just being developed. There was no surgical staplers. There certainly wasn't any minimally invasive surgery. So it's not surprising that the mortality was incredibly high. But if you look at the patients who survived, they had a tremendous improvement in their respiratory physiology that was durable for, I think, at least a year at the time of this publication. Joel Cooper, like nothing in medicine is new, but Joel and others, I think, discovered this history in the 90s and began to experiment with reintroducing this concept of reducing the size of both lungs. Joel went at WashU at the time, did it through a median sternotomy so he could approach both lungs at the same time. And in 1995, published his first initial experience with 20 patients and demonstrated that this could be done with acceptable morbidity and mortality. I think the mortality in his early series was just one patient, 30-day mortality. And then followed that up in short order in the next year with their first series of 150 lung volume reduction operations, again, with acceptable 30-day mortality. At the same time, this was being done across the country in smaller hospitals all over the place. People were just doing this. It really wasn't, it was a wedge resection, so you could code it and bill it and get reimbursed for doing this, and you could do it bilaterally. And a lot of these patients are in the Medicare population, and Medicare wasn't called Medicare then, it was called HCFA, but HCFA said, wow, we're paying for a lot of these new operations. How are they really doing? And while the 30-day mortality was somewhere between 2 and 5%, these patients were 3 times as likely to be readmitted to the hospital in the year following their LVR surgery than they were in the year prior. So it wasn't clear to the payer that this was a good idea, and they just stopped payment in 1995. This is at a time when the surgical community was getting all fired up about how to do this operation. There were people using lasers to melt the top of the lung and doing all kinds of interesting things to create volume reduction surgery. And it came to a screeching halt because you could no longer get it paid for. That created quite a turmoil in the beginning of this whole conversation about equipoise, about whether this is really an advance. And so in response to that, and this happened in very short order, CMS or HCFA at the time and the NHLBI said, all right, let's get a consensus group together and start talking about whether this is a good thing or not and what we should do about it. And that was the genesis for the NET trial. There were 18 centers that submitted an application to be participants in this. Dr. Cooper was a very vocal member of this. It was a very interesting time to go to a bunch of these meetings. It was a great demonstration of equipoise. And in very short order, the NET trial was organized. And at the time it was organized and opened, all 18 centers were in agreement to participate. And then just as we got to start enrolling patients, WashU withdrew because they felt they didn't know, as an institution, did not have the same equipoise that the other 17 centers. By then I had moved from the Brigham to the Cleveland Clinic, and the NET investigators sat in alphabetical order. So I sat between Columbia and Colorado for the next 12 years at all the meetings. So it was kind of an interesting time. So NET screened a little over 3,000 patients and enrolled 1,200 and randomly assigned them to either have lung volume reduction surgery bilaterally or best medical therapy. Both groups had to go through pulmonary rehab. Both groups had maximal medical therapy. The volume reduction could be done by median sternotomy or by V.A.C.S. And we began accruing patients, and it took quite a while to accrue these 1,200 patients. There was a tremendous amount of debate as we created the entry and inclusion and exclusion criteria for NET about which morphologies of emphysema to include. We've learned a lot from the National Emphysema Treatment Trial, but the consensus was the entry criteria were going to be mostly physiology based on FEV1 and diffusion capacity. That ventilation perfusion scans were going to be used by the surgeons to pick good targets to remove things that were ventilated but not perfused, or clearly not helping in the business of breathing. But it wasn't until the pivotal trial was published in 2003, so now 6 to 7 years, or 8 years since we were able to do this surgery, the surgeons had to sit on their hands for 8 years and had very little to talk about because it was a randomized trial, and until we had the patients through their follow-up, we really couldn't discuss much. But the punchline was that in that randomized trial, there was a population that had improved survival. That was a surprise, and I'll talk more about that in a moment. But there was consistent improvement in exercise capacity and respiratory specific quality of life for those patients that had volume reduction surgery. So before we get to the survival, and survival was the endpoint in the NET trial, and the nice thing about survival is that there's complete, there's no debate about whether the patient's alive or not. So it's a nice hard endpoint. But the operation has some substantial morbidity, and any of you in the room that have done that know it is not technically the most demanding thing. It's just a giant wedge resection on both sides, but they're really difficult patients to take care of. It's also at a time when we recognize, for example, our STS database, which does 30 days of follow-up, is probably not adequate for us to really understand the morbidity of some of the things we do. We've got really good critical care colleagues, and we can take care of people. We can keep them alive in the ICU for a long time. So 30 days isn't necessarily the right benchmark. Whoop. Power outage. All right. So, but if we looked at 90 days, the mortality in the NET trial was 5%. And the 30-day mortality was 90% of people had an air leak. More like 75% of people had an air leak in the OR, but by the next day, 90% of people had an air leak, and half of those lasted more than 7 days. So air leak was, a big deal, not a surprise. The vast majority of the patients in the NET trial had buttressed wedge resections you could use whatever buttress you want. There was 30% major pulmonary complications and 20% major respiratory or cardiovascular complications. So it's not a slam dunk easy thing to do. However, with mature follow-up, if you're a clinical trials purist, here are the other curious thing about the NET trial, since the other half of my life is in cancer, we look at survival deteriorating. So we have, we look at survival. The NET chose to look at mortality. So here we have advancing mortality as we go forward. In the medical group in yellow, no surprise, the surgery group had excessive mortality early, but those survival curves crossed at 2 years. There was no survival advantage with 2 years of follow-up. That was in the 2003 New England Journal paper. But with mature follow-up of the whole study, the surgical group had better survival, statistically significant. Does that mean we should offer lung volume reduction surgery to everyone with emphysema? No, we learned some other things in the NET trial. We learned that there were 2 independent predictors of outcome. Number one was the pattern of emphysema. Upper lobe predominant people with upper lobe predominant emphysema responded better to this intervention than people with homogeneous diffuse emphysema, or what we call cotton candy lung, or other patterns of emphysema. And folks that, despite best medical therapy and pulmonary rehab, still couldn't do very much in terms of exercise, they did better with surgery, or turn that around, as I would talk to my pulmonary colleagues, continued medical therapy for that group is kind of futile. They're beyond the ability of all your inhalers and things to help. So if we I think the batteries ran out. If you just look at that group that has upper lobe predominant emphysema and poor exercise capacity despite going through rehab, and this is corrected for the number of watts between what men do and women do and things like that, there is a highly statistically significant survival advantage to the folks that had surgery with a risk reduction of death of 43%. So, you know, I think most of us as surgeons felt duh, we knew this was going to happen. Joel Cooper for sure felt that way and said, well, I told you so. And, you know, we could conclude that in patients with the right pattern of emphysema, there was a survival advantage, a durable improvement in exercise capacity because we followed them all for 5 years, a durable improvement in quality of life, respiratory specific quality of life. That yes, they declined over 3 to 5 years, but since we had a control arm, they were still well above what their medically managed partners experienced. And so we were encouraged. And CMS very quickly, after publication of the NET trial, reinstituted payment for lung volume reduction surgery in patients that this publication suggested would benefit. And there was concern, despite that payment decision, that this was going to bankrupt Medicare. So we tried to do a little study to try to understand, this isn't 2 million people that are going to show up on the in your office for clinic later this afternoon saying, I need volume reduction surgery because I'm going to live longer. If you just we looked at our PFT database at Beth Israel and found the people that had obstructive lung disease, and then found those that had a CT scan and looked at those that had the upper lobe predominant pattern, and then culled those that had chronic bronchitis or other airways disease. And we got down to just only 15% of the total population, and understanding that not all 15% of those people are going to even qualify for other comorbidities. So we didn't think that it was going to bankrupt Medicare. However, in the couple of years after publication of the NET trial, across the entire country, in 2005, only 207 cases, at least submitted claims to Medicare for reimbursement. The following year, only 144 cases. And I looked up the University of Wisconsin's experience over 14 years from 2009 to just last year. We do on average 8 cases a year. So despite the fact that we've demonstrated the only thing since supplemental oxygen to improve survival in emphysema, doesn't appear that the NET trial, 1,200 patients, and I forget, 20 to $50 million, depending on how you figure it, of our taxpayers' money, us, really hasn't changed our practice. So kind of frustrating, but a very enlightening experience nonetheless for me personally. It was a unique collaboration at the federal government level. For the first time, we had NHLBI, the NIH paying for the experimental costs of participation, and CMS saying we'll pay for all the clinical costs. And we did some interesting quality of life and cost effectiveness that came out of this. And LVR was on par with heart and lung transplantation and ICD use in terms of cost effectiveness, but still has not changed practice. All right, so let's move on to another topic. Being here in Denver, it's the United Hub. You guys recognize this. This is going to be a picture of historical significance since the 747, which was the long haul horse, if you will, for long haul air travel, is being retired or has been retired. So this is a familiar sight, and the sky is over Denver for the last couple of decades. And this would be front page news. We picked on American Airlines here, but this is a 747 that crashed in 2001. And that's front page news when that happens. And 411 people perished in that. Well, friends, this is how many Americans die every day of lung cancer. That's not front page news, but it happens every day, 365 days a year. So, it is a substantial problem. And we understand primarily in 85% of the patients what causes it, that we don't do that much about it. It's responsible for more annual deaths than breast, colon, prostate, and pancreatic cancer added together. And when you look across the country, not that I know most of you in the room probably know this, but there's a lot of the general public that don't. So why is it? Well, this is the unfortunate reality about lung cancer is that 65 to 70% of lung cancer is diagnosed in an advanced stage, stage 4, where we can improve survival, and we have, and all the fancy research, and you see is, a leader in lung cancer and oncologic research has improved the survival from 1 year to 2 years in stage 4 disease. But we unfortunately find very few patients in early stage disease where the tools in our toolbox as surgeons can lead to cures. So this was the genesis, if you will, for the National Lung Screening Trial. All right. Screening had been attempted in lung cancer for the last 50 years. We just didn't have the best tools. There's 3 large screening trials done in the 70s looking at sputum cytology and chest X-ray that showed no reduction in lung cancer related fatality with the screening program. But now we have CT scan, and we have low dose CT scans. And if anyone's ever had one, a low dose spiral CT scan takes about 20 seconds. And you get a tremendous amount of information. So this was the genesis for the National Lung Screening Trial. 50,000 high-risk patients that were, and this was really enriched for substantial surgical risk. These were patients with a 30-pack year smoking history. They had to be active smokers or quit within the last, 10 years, and ages 55 to 79. And the trial was designed to look for a 20% risk reduction in lung cancer specific mortality up to 5 years. So the trial was begun. Enrollment happened between 2002 and 2004. That means the screening, which was 2 years, there was an incidence scan and then 2 prevalence scans. So that's 2 years, continued to 2007. So by 2009, you had 2 years of follow-up on even the last patient in the trial. And there was 90% adherence to participation in this trial, which is tremendous, which is, if there are any research coordinators in the audience, hats off to you, because you kept people on trial and made sure they showed up for their follow-up. We'll talk a little bit later about why that's a problem going forward. At a substantial cost to us taxpayers, $200 million to do this. So, quite an undertaking. And the New England Journal publication is on the left in 2011, the NLST in 2020, the Nelson trial, which is a similar trial done in Europe, in Belgium and the Netherlands, with very similar results. A substantial, statistically significant risk reduction for mortality in the screened group. And why is that? Well, the simplest explanation, if you look on the pie graph to the right, 65% of the cancers that were detected in LST are stage 1. Stage 1 needs a lobectomy and typically no adjuvant therapy, though we might talk a little bit about adjuvant therapy for stage 1 disease at Tumor Board later today. So this was a tremendous, a tremendously positive thing, and I was really excited when I forget, I was traveling when I heard about them stopping the trial. They had reached their statistical endpoint, and we couldn't wait for this to get published. And following the publication, the way this works is the U.S. Preventative Services Task Force then looks at the evidence and then pretty quickly issued a coverage decision that covered lung cancer screening. By coverage, I mean it's free, at least for Medicare and Medicaid patients, and almost all of the third-party payers have to follow suit for patients that fit that risk criteria. And very recently, the USPSTF
that task force. I can't pronounce all those letters all at this hour of the morning. Enriched or changed the criteria for screening, which has been another positive thing. They reduced the smoking dose, if you will, to 20 pack years, and lowered the lower age to 50 and went up to 79. And the advantage of that is it's made screening more accessible, not only to white men and women, but also underrepresented minorities. So if we look at this next slide from Helio, it shows that now there's a 75 to 78% increase in the availability of screening services to these underrepresented minorities. So that's the positive. But does lung cancer screening really work? Seemed to work in this trial with 90% penetrance. How is it done in other common malignancies? Here's data over 3 or 4 decades in colon cancer. So in 1985, the U.S. Preventive Services Task Force was created. It's also the year that President Reagan was diagnosed with colon cancer based on a colonoscopy. And you can see that the screening recommendation for colorectal cancer began then, and it took a little bit of time before you see a mortality reduction for both men and women. But what you do see on the top curves is a steady decline in the incidence of invasive cancer, presumably because of early detection of polyps, and polypectomy, and avoiding getting to that point of invasive cancer. But it takes quite a while. By 15 years after this first guideline publication for colorectal cancer, only about 1 in 3 of patients who were eligible for screening actually had it in colorectal cancer. So it's not been a home run. Still, the things continue to improve in colorectal cancer screening, and now the penetrance, if you will, or the prevalence of screening or adherence to screening in a variety of populations is closer to 65 to 70%. So 2/3 of our population are being screened. But it's frustrating that it takes such a long time for something that's demonstrated to have a mortality benefit, becomes common practice. What about mammography? Well, here's like 3 decades of mammography crammed into one little slide, and you can see the bar graph at the top. Again, the initial mammography recommendations, have taken quite a while to get up to, again, around 70% adherence. I was surprised at this data. I thought it would be much higher than 70%, but still. And very similar to the lung cancer screening trial, the advantage there is that these screen detected cancers, breast cancers, tend to be early stage and obviously more likely to be cured with less, perhaps less costly interventions. It's resulted in substantial reduction in mortality in almost every age group except the very young. But screening began in 1987, and it took 10 years before you start to see a decline in mortality and a substantial improvement in outcomes. But it's taken 3 decades to realize this. So, and then this is the point I made earlier, is that the screening mammography has resulted in detection of more in situ cancers and more early stage cancers, and a rather steady state of stage 2 to 4 disease. So the benefit has been earlier detection, which I would submit as surgeons we should be major champions of. In Europe, lung cancer screening has greater penetrance. This is a meta-analysis published in The Lancet a couple of years ago, which includes the Nelson trial, but some other trials there, that shows a continuing divergence in terms of survival amongst the screened population versus the control arms. And a lot of our European colleagues benefit from the fact that they have essentially nationalized healthcare, and so it's perhaps easier to embed screening practices in primary care than what we face here in the United States. 10 years after publication of the NLST, You know, even in trials, from institutions that are focusing on screening, they're having trouble keeping patients like showing up. 55% of these 16,000 high-risk adults complete the prescribed screening recommendation. And even more sobering, if you look at just the prevalence of screening across the common cancers, lung cancer is down there at 5%. And with the U.S. Preventative Services Task Force new recommendations, it was, I think, 8 or 9%, but by increasing the denominator, it's made it look even worse in the sense that only 5% of those eligible right now, more than a decade after publication of the NLST, are really getting screened. So has NLST really changed practice? Has this large 50,000 patient randomized trial? Maybe a little bit, but not much, and we still have a long way to go. So I want to conclude by just talking about what the barriers to this stuff are. Screening seems to work, but it takes decades. And why is that? So the scientists, the ivory tower debate is like, oh, there's fear of overdiagnosis. And prostate cancer is probably a good example of fear of overdiagnosis because we have, blood tests that can suggest invasive or suggest prostate cancer. And it's true that a lot of men can die with prostate cancer without dying of prostate cancer. That's really not the truth in lung cancer. There are no autopsy studies that show this high prevalence of occult lung cancer that doesn't kill people. I do think that the ground glass opacities that the thoracic surgeons understand is the sort of scourge of our practice these days. Maybe a little bit of this overdiagnosis bias argument, but that is not the 20, 30 pack year patient smoker. And we have evidence, really strong, grade A, level 1 evidence that, we should screen those people and find those early cancers and take them out. The other bigger problem, I think, is that it's the specialists that are debating and organizing these randomized clinical trials, trying to redefine, what the standard of care should be, whether it be a new operation or just, an appropriately applied screening recommendation. But we then have to, who's our audience? We got to go talk to the primary care docs and get these things embedded in their practice. And it should be unacceptable, in my opinion, that it takes 3 decades for that to happen. As surgeons, we wouldn't be allowed to spend 30 years futzing around with a procedure. It's either going to work or it's not, or people get hurt. And yes, they don't get hurt as quickly in not applying screening, but they're still being hurt. And then the last issue is just overall funding. So a couple of things, this isn't just related to surgical interventions. There's plenty of medical, preventative medicine things. Here's 2 examples. Beta blockers, the cardiac surgeons will know this, are demonstrated to improve survival in patients after MI. And, it's part of our STS best practice guidelines that make sure all our patients who have coronary revascularizations leave the hospital on a beta blocker. These were recommended by the American Heart Association, the American College of Cardiology in 1999. As of 2014, only half the time, if you in electronic health reviews, were patients on a beta blocker. Same thing for our neurology colleagues, the Headache Society and the Academy of Neurology have guidelines showing migraine prevention with a beta blocker back as early as 2000, and only 33% of them 12 years later had this intervention established in their care. So it's not just about surgical interventions. It's about that transition from science and clinical trials and what generates these preventative recommendations and how do we get them in the practice. I don't have all those answers, but I think one of the problems is that federal dollars, this is 2017 data for breast, colon, prostate, and lung cancer, per patient death. And I'm not suggesting we take money away from breast cancer research. I think we start looking, though, at the fact that we still have a number of Americans dying every year of lung cancer, and we're not spending enough on changing that. Some of those dollars could be spent on getting more people to be screened appropriately. A lot of it is being spent on, targeted therapies and immunotherapy, and that's all great. But if we could just get more of these things discovered early, we could fix them much simpler. So like a lot of grand rounds you probably go to, I am giving you fewer answers and hopefully stimulating more questions. But I appreciate your attention, and thank you again for the opportunity to be here with you today.
That was a terrific talk. We have time for some questions. Rich?
Dr. DeCamp, thank you so much for visiting us and delivering this very insightful talk. I have two questions, maybe comments. First is, don't we have an opportunity with an electronic record to not have physicians deciding who gets screening for what, but using artificial intelligence to tell the physician, look, time for this screening or time for that screening? So that's my first one. You want to take it one at a time?
Sure, I'll address that. And Epic is a suburb of Madison, or Verona. Epic lives in Verona, and it's a suburb of Madison. But one of the most contentious things in electronic health record is a hard stop. I'm a big proponent of putting a big red flag on the primary care people's Epic thing, like, hey, this person has this much smoking history, they qualify for screening. So I think that would be a good idea, but it's hard to increase work on my primary care colleagues. The other thing is that it will really depend on how well the patients are queried and how honest they are about their smoking exposure. And I was just reading something in the last 2 days about, since the pandemic's ended and we're moving back from virtual to the in-person environment, that there's a big time decrease in the amount of smoking related data that's collected, when you visit your primary care doc. And those two things would have to go hand in hand for the AI solution to work.
But it seems like to move it from 5% to 20% would be a great success. And
that's a lot of people if you could move from 5 to 20%. So I agree, incremental progress. And so I think anything we could do to stimulate that. And I constantly am bugging folks at Wisconsin, can you get me in front of the primary care docs? I just want an opportunity to talk to them. Because I don't think this is malice or laziness. I think they're just not aware.
My second question, so, what about liquid biopsy? So there's a ton of activity in the cancer center about, sending blood tests off and screening for this and screening for that. Where do you think that will sit for lung cancer? And maybe that obviates the need for a CT scan.
Yeah, I think cell-free DNA and, I think there's a lot of promise with other kinds of biomarkers that perhaps don't carry the same risk. I think there was a lot of concern when NLST was published because of, I don't know, I think it was 20 to 1, how many CT abnormalities were detected versus what were really cancer. But NLST was pretty thoughtful about how they created an algorithm for what you're supposed to do. So there weren't a lot of non-therapeutic thoracotomies and, willy-nilly invasive procedures, and therefore not a lot of people hurt, though that was a fear. The other crazy fear was the quote radiation exposure from a low dose CT scan, which I think got way too much play. It's the same amount of ionizing radiation you get if you fly from New York to LA in one low dose CT scanner. And the third barrier was this requirement for shared decision-making and the documentation around it, which is a good idea in theory, but it just creates another barrier in terms of practice. So the CT is really easy to do and procure and get, but the paperwork prior to that is onerous. So if we could come up with a different kind of biomarker, a blood test, which most patients won't think is difficult, or a buccal swab to look for a field cancerization problem. You know, it may make this lecture obsolete.
Thank you.
Mac, I also want to thank you for visiting and a fantastic lecture. I want to ask about the NET trial and why you think that, and maybe without being too provocative, do you think part of the issue for the lack of adoption is because there wasn't a device involved? In other words, you look at TAV, or you look at bad trials, there's been change based on those randomized trials, but here's a therapy that by the data works, but 120 operations is really small. So comments on that?
Yeah, I think, and I have other talks about the reasons why NET didn't result in more surgery. And some of it was this big gap of time. So the momentum from the mid 90s until the mid 2000s where nothing happened. So surgeons sort of a little bit lost interest. We're not the gatekeepers for these patients, pulmonologists are. And I think the first publication after creating the NET was published in the New England Journal and says, patients at high risk for death from lung volume reduction surgery. That was the title. So if you just read the title, you're done. Now, what it meant was there was a subset of patients early in the NET trial, which we realized had excessive mortality. And those were patients with very low FEV1s, very low DLCOs that Joel Cooper thought he could still operate on, but the rest of us found were like too high risk. So there was that publication bias, if you will. And then at the same time NET was coming out, there was an explosion of interest in a variety of bronchoscopic devices to effectively perform volume reduction surgery, albeit with way lower morbidity. And I was involved with a whole bunch of those, and I'm on the data monitoring safety board for yet another one that's ongoing now, but none of them have produced the kind of benefit here. They're lower risk, but lower benefit. And only one of those devices, the pulmonx valve, has been approved. You have to have complete fissures. You have to prove there's no collateral ventilation. And unlike TAVR, for example, where no debate about aortic stenosis and how critical it is, and you have a surgeon and a cardiologist who decide, is it feasible to do a TAVR or not? We haven't developed that lung team like you have the heart team, but I think you probably do here, and we have it in Wisconsin. We have a multidisciplinary group that talks about transplant LVR and bronchoscopic LVR for the COPD patients all the time, but it's not taken off the way TAVR has.
All right. Well, that was a terrific talk. I want to thank Mac for coming out from Wisconsin to give it. Mac, we have a few things for you in a bag behind me that we'll look at later. But thanks again. I'd welcome everybody to stay for our debate. It's going to revolve around board certification and subspecialization attached to that certification. So thanks again.
Thank you. What you were looking for?
Yeah.
They engage more.